Hello there, everyone. In this module, we'll be learning about scoliosis. Let's begin with a quick introduction. Scoliosis refers to the abnormal sideways curvature of the spine, manifesting as a deviation from a straight vertical line. There are two main classifications of this condition: nonstructural or transient, and structural or permanent. First, we'll talk about nonstructural scoliosis. Nonstructural scoliosis is characterized by a transient or mobile curvature, where the vertebrae are tilted sideways but not rotated along their long axis. Three subtypes fall under this classification: postural, compensatory, and sciatic scoliosis. Postural scoliosis is the most common subtype, frequently observed in adolescent girls. The curve, usually mild and convex to the left, straightens entirely when the individual bends forward. Compensatory scoliosis is a variant that develops as a result of a compensatory adjustment for pelvic tilt due to conditions like hip disease or a short leg. The scoliotic curve disappears upon examination in a sitting position or once the underlying cause is addressed. Sciatic scoliosis occurs due to a unilateral painful spasm of the paraspinal muscles, often triggered by a prolapsed intervertebral disc. Now for structural scoliosis. Unlike the non-structural variant, structural scoliosis involves a permanent deformity with both lateral curvature and vertebral rotation. It includes several subtypes. Idiopathic scoliosis is the most prevalent type of structural scoliosis and may occur at any life stage: infancy, childhood, or adolescence. The progression rate varies, often leading to significant deformity, particularly in thoracic scoliosis, marked by a visible rib hump. The curves usually progress until skeletal growth cessation. Congenital scoliosis is always associated with a radiologically identifiable anomaly of the vertebral bodies, such as the hemivertebrae, block vertebrae, or unsegmented bar. These curves tend to progress rapidly and may also be associated with neural growth anomalies, potentially causing lower limb neurological deficits. Paralytic scoliosis occurs due to unbalanced trunk muscle paralysis. Common causes include poliomyelitis, cerebral palsy, and muscular dystrophies, especially in developing countries. As for other pathologies, certain diseases like neurofibromatosis can also cause structural scoliosis, resulting in sharp kyphoscoliosis. Now let's talk about the pathology of scoliosis. The defining pathology of scoliosis is the abnormal lateral curvature of a portion of the spine, referred to as the primary curve. Along with this lateral curvature, there's often rotation of the vertebrae. Primary curve is a term that denotes the primary or main area of curvature in the spine. This abnormal lateral curve is the defining feature of scoliosis. Secondary or compensatory curves develop either above or below the primary curve as a compensatory mechanism in an attempt to maintain the body's balance. These are termed compensatory or secondary curves and tend to curve in the opposite direction to the primary curve. There's also vertebral rotation, where the vertebrae within the primary curve often rotate along their long axis in scoliosis. This rotation is a significant contributor to the three-dimensional deformity seen in scoliosis. There's also the rib hump. In cases where the primary curve is located within the thoracic spine, the rotation of the vertebrae can lead to prominence of the rib cage on the convex side of the curve, leading to a visible and palpable rib hump. The thoracolumbar section of the spine, where the lower thoracic spine meets the upper lumbar spine, is commonly affected in scoliosis. The progression and pattern of curvature tend to follow certain trends depending on the exact site of the curve within this region. Three notable patterns based on their location include the following: Dorsal scoliosis. This occurs when the curve is primarily in the thoracic or dorsal region of the spine. This type is often accompanied by a noticeable rib hump due to vertebral rotation. Dorso-lumbar scoliosis. In this type, the curve spans the lower thoracic or dorsal spine and the upper lumbar spine. The prominence or symptoms associated with this type will depend on the exact vertebrae involved and the degree of the curve. Lumbar scoliosis. When the curve is primarily within the lumbar section of the spine, it's termed lumbar scoliosis. Depending on the severity and exact location, it may cause changes to the waistline symmetry or other postural changes. Now let's talk about the clinical features. Scoliosis can often be detected during routine physical exams, school screenings, or when patients present with concerns about upper body asymmetry. In severe cases, particularly in infants or juveniles, patients may experience restrictive lung disease due to their spinal curvature. When taking a patient's history, it's crucial to gather information about the timing, rate of progression, associated symptoms such as pain, weakness, respiratory or bowel/bladder issues, and family history. This information can help determine the underlying cause of scoliosis, if discernible, and identify risk factors for curve progression. In many cases, the only symptom is a visible deformity. Visible deformity. This is the most common symptom of scoliosis, particularly in less severe cases. The individual may appear to have a tilted posture, uneven shoulders, asymmetry in the waistline, or a prominent rib hump on one side. Pain. Although scoliosis in children and adolescents is typically painless, adults with long-standing scoliosis may experience back pain or discomfort. This is usually due to the degenerative changes that can occur over time. Neurological deficits. In extreme cases of severe long-standing scoliosis, the spinal cord may become sharply angled over the apex of the curve. This could lead to interference with spinal cord functions and potentially result in neurological symptoms, such as muscle weakness, numbness, or coordination difficulties. However, such cases are quite rare. Now let's learn about the physical examination. The comprehensive physical exam should encompass several aspects. For the general exam, measure the patient's height and arm span, assess the Tanner stage of development, evaluate skin and joint laxity indicating a potential connective tissue disorder, conduct a skin exam for signs of hyperpigmentation or abnormal vascularity suggestive of neurofibromatosis, check for bony asymmetries, examine the feet for high arches and claw toes, signs of neuromuscular disease, and complete a full neurologic exam. For a scoliosis-specific exam, inspect for any visible curvature abnormalities and perform the forward bend test. In this test, the patient stands with their legs together, knees straight, and then bends over at the waist until their spine is parallel to the floor, with their arms hanging down. The examiner stands behind the patient to observe any prominence in the thoracic or lumbar region, which would highlight the rotational component of scoliosis. To quantify the degree of trunk rotation more accurately, a tool called a scoliometer or inclinometer can be used. This can help determine the need for radiographic imaging. It's essential to remember that the degree measured on the scoliometer doesn't equate to the Cobb angle, which is calculated from imaging studies. Now let's talk about the diagnostic workup. The confirmation of a scoliosis diagnosis, as well as the determination of its type, severity, and risk of progression, relies on the use of radiographs. The initial evaluation should include standing posterior, anterior, and lateral views. In preparation for surgical evaluations, lateral bending views are typically obtained. The diagnosis of adolescent idiopathic scoliosis is established both clinically and radiographically. The criteria for adolescent idiopathic scoliosis include an age greater than 10 years, a Cobb angle exceeding 10 degrees, and the exclusion of other potential causes for scoliosis. Let's go through the indications for plain radiography. Plain radiography is suggested in the following scenarios. Clinical evidence of spinal curvature. If the physical examination reveals signs of spinal curvature, plain radiography should be performed for confirmation and further evaluation. Scoliometer reading greater than 7 degrees, generally regarded as an indication for plain radiography, as it signifies a significant degree of trunk rotation. Thoracic or lumbar asymmetry in growing children or those with a family history. Any signs of thoracic or lumbar asymmetry in children undergoing growth spurts or in individuals with a familial history of scoliosis warrant radiographic evaluation. Monitoring progression in previously diagnosed patients. For patients with a known diagnosis of scoliosis, periodic plain radiography is crucial to track the progression of the spinal curvature. This allows for timely intervention if the curve appears to be worsening. Let's go over the imaging requirements. A comprehensive assessment of scoliosis typically involves full anteroposterior and lateral X-rays of the spine in both supine and standing positions. Cobb's angle. This measurement is used to quantify the severity of the scoliotic curve. It is defined as the angle between two lines, each drawn parallel to the superior end plate of the uppermost tilted vertebra and the inferior end plate of the lowermost tilted vertebra. Progression assessment. To determine the likelihood of curve progression, radiologists may examine the iliac apophysis, a part of the pelvic bone. As this area fuses with the main part of the iliac bone when skeletal maturity is reached, its status can provide a clue about whether further worsening of the curve is likely. This is referred to as Risser's sign. Vertebral rotation. Rotated vertebrae can be detected by looking at the position of the spinous processes and pedicles on the AP view. In normal circumstances, a spinous process is centered within the vertebral body. If a vertebra is rotated, the spinous process appears shifted to one side, and the pedicle's position will be asymmetrical. In addition to these general features, specific types of scoliosis may present characteristic radiological findings. Congenital scoliosis. Features might include wedging of the vertebrae, hemivertebrae or half-formed vertebrae, unsegmented bone bars between vertebrae, or fused ribs. Scoliosis associated with neurofibromatosis. Radiological signs could include erosion of the vertebral bodies or widened intervertebral foramina due to dumbbell-shaped neurofibromas. Next, we'll talk about the principles of scoliosis treatment. The goal of scoliosis treatment is to prevent the progression of the curve and manage any physical deformity or discomfort it may cause. Several factors influence the prognosis and treatment approach, including type of curve, age at onset, and location of the curve. Here are the predictors of curve progression. Congenital scoliosis. Curves caused by congenital spinal malformations tend to progress more rapidly than idiopathic ones. Neurofibromatic scoliosis. Curves associated with neurofibromatosis also progress faster. Age. Younger patients are more likely to have curve progression, which can worsen with growth spurts. Curve location. Thoracic curves often produce more severe deformities. Now we'll go over the treatment approaches. When a curve is identified as likely to progress and result in significant deformity, spinal fusion may be recommended. The guiding principle is that a straight, rigid spine is preferable to a curved, flexible one. First, non-operative treatment. Postural curves and structural curves less than 30 degrees, as well-balanced double curves, can often be managed non-surgically. This typically involves a combination of exercises to strengthen the spinal muscles and bracing to support the spine. Bracing options include the following. The Milwaukee brace. Designed in Milwaukee, this brace is custom-made and used for curves high in the spine. The Boston brace. This is more cosmetically pleasing and is used for curves in the lower spine. Risser's turnbuckle cast. A body cast with a turnbuckle that can be tightened to stretch the concave side of the curve, thereby correcting the deformity. The localizer cast. This is a body cast applied with the spine in traction and requires a special localizer table. The progression of the curve is monitored through regular clinical and radiological evaluations, typically every 6 months. Now for operative treatment. Indications for surgical intervention include congenital scoliosis with a high risk of rapid curve progression, curves that are worsening radiologically and likely to cause significant deformity, and scoliosis associated with back pain. Surgery often involves spinal fusion and possibly corrective techniques. In congenital scoliosis, simple fusion is usually sufficient. In idiopathic scoliosis, correction is attempted before fusion using traction methods, such as Cortel traction, a localizer cast, or a halopelvic distraction system. During surgery, distraction systems like Harrington's distraction system, Dwyer's compression assembly, or Luke Hartzell systems may be used to achieve further correction. Now let's have an image-based discussion. Here is a radiograph showing an S-shaped thoracolumbar scoliosis without segmentation abnormalities. The sagittal curvature of the spine is within the limits of the normal range. In this radiograph, after the end vertebrae of both curves have been established, lines are aligned with the end plates, between which an approximately 30-degree Cobb angle can be measured for both deformities. Here is a radiograph showing a Cobb angle measurement. This is a radiograph imaging showing Risser's sign. Risser 0 has no ossification center at the level of the iliac crest apophysis. Risser 1 is approximately 25 apophysis of the iliac crest. Risser 2 is approximately 25 to 50% apophysis of the iliac crest. Risser 3 is approximately 50 to 75% apophysis of the iliac crest. Risser 4 is approximately 75% apophysis of the iliac crest. And Risser 5 is complete ossification and fusion of the iliac crest apophysis. The ossification of the iliac apophysis creates the Risser's sign. X-rays can be taken in which the patient lays on the table and bends to the right and then to the left to assess the flexibility of the spine. In this image, radiographs were performed without the brace on the left and with the brace on the right. Let's talk about the Cobb angle measurement for scoliosis. The Cobb angle, shown by the arrow in the radiograph, is formed by the intersection of a line parallel to the superior end plate of the most cephalad vertebra in a particular curve, with the line parallel to the inferior end plate of the most caudal vertebra of the curve. The intersection of these lines may occur outside the border of the actual film. Therefore, by convention, perpendiculars to the parallels are drawn, and the angle between their intersection is measured. The Cobb angle in the above radiograph is 63 degrees. The most cephalad end vertebra, or E1, is the vertebra that has the greatest tilt from the horizontal of its superior end plate, or the solid line. The most caudal end vertebra, or E2, is the vertebra that has the greatest tilt from the horizontal of its inferior end plate, or the dotted line. The apical vertebra, or A, is the most laterally deviated vertebra from the midline. Drawing lines along several vertebrae near each end of a curve, or the dashed lines, is helpful in determining that with the greatest tilt. Now for the Adams forward bend test for scoliosis. The Adams forward bend test demonstrates the rotational component of scoliosis. It is performed by observing the patient from the back while they bend forward at the waist until the spine becomes parallel to the horizontal plane. The patient's feet should be together, knees straight ahead, and arms hanging free. Asymmetry of the upper thoracic, mid-thoracic, thoracolumbar, and lumbar region is noted. Thoracolumbar scoliosis. Here is a postero-anterior radiograph demonstrating right thoracolumbar scoliosis. The air fluid level in the stomach confirms that the radiograph was taken with the patient standing. Scoliosis radiographs are viewed with the patient's heart on the examiner's left, as if the examiner is standing behind the patient. Scoliosis. Signs of scoliosis include one shoulder that is higher than the other, a shoulder blade that sticks out, and a skin fold or crease at the waist. This is a radiographic image of neuromuscular scoliosis. Panel A shows a preoperative postero-anterior radiograph of the spine of a patient with spastic quadriplegic cerebral palsy with a 73-degree thoracolumbar scoliosis and pelvic obliquity. Panel B shows a postoperative postero-anterior radiograph of the same patient, following spinal fusion with pelvic fixation. This is an image of truncal asymmetry in scoliosis. The back should be exposed so that the iliac crests and posterior and anterior aspects of the superior iliac spines are visible. The examiner inspects the back from behind the patient. Findings of scoliosis include lateral curvature of the spine and asymmetry of the shoulders, scapulae, waistline, or the distance that the arms hang from the trunk. Lateral curvature of the spine and asymmetry of the shoulders, scapulae, and waistline are evident in the patient depicted above. Thank you for listening to this module about scoliosis.